A 46-year-old man arrives at the emergency room with rapidly worsening cognitive decline. He is confused during basic questions. He cannot recall recent events, and according to his family, his personality has changed over the past several months. Initial assessment suggests possible early-onset dementia. But there is a problem. The speed of decline does not match typical neurodegenerative disease. Neurological examination reveals impaired short-term memory, disorientation, and subtle motor abnormalities that are difficult to explain. A brain scan is ordered. No tumor is identified. No acute stroke is seen. No clear structural cause explains the severity of symptoms. Blood tests are reviewed. No metabolic abnormality is found that could account for the progression. At this point, clinicians begin considering less common neurological and infectious causes. Then a detail emerges from his medical history. 12 years earlier, the patient developed a localized skin rash. It was not painful, it was not treated, and according to his report, it resolved spontaneously within a few weeks. No follow-up was performed at the time. No diagnosis was confirmed, and it was assumed to be a benign dermatological reaction. For 12 years, the patient remained completely asymptomatic, functioning normally. He worked, he traveled, he made plans for the future, completely unaware that the real disease had never left until now, because what initially appeared to be an isolated and self-resolving skin condition may not have resolved at all. And the current neurological decline may represent a delayed systemic progression of the original infection, because while the rash disappeared from his skin, something far more dangerous had already begun its journey toward his brain. This is the story of how one ignored warning sign would return more than a decade later and nearly destroy his mind. Alexander Skarsgård wasn't going to make it.
This is Hidden Pathogens?
Doctors begin with the most likely explanation, early-onset dementia. It would explain the memory loss. It would explain the confusion. It would explain the personality changes. But there is a problem. The timeline does not fit. The decline is too rapid, and in some moments, the symptoms fluctuate in a way that is not typical for degenerative brain disease. A full neurological examination is performed. The patient struggles with basic recall tasks. He cannot accurately repeat recent information. He becomes disoriented even within the hospital environment. But the physical findings raise more concerns. Subtle coordination issues begin to appear. His movements are slightly unsteady. Not enough to immediately suggest a stroke, but enough to suggest something is affecting the brain at multiple levels. A brain scan is ordered immediately. CT scan shows no bleeding, no tumor is identified, no obvious structural abnormality is found. At this point, the medical team begins to reconsider the initial diagnosis. If it is not dementia, and it is not a stroke, then what is causing a previously healthy man to deteriorate this quickly? Blood tests are reviewed. No metabolic imbalance is found. No clear toxic exposure is identified in the initial screening. The case becomes increasingly unusual. A neurologist is consulted. Then an infectious disease specialist is brought in. Because when neurological decline progresses this quickly without imaging findings, doctors begin to consider one critical category: hidden infections. But nothing in the patient's current history explains a possible infection of the brain until a single detail appears in his past medical record. A detail that was never considered important at the time. 12 years earlier, a rash had appeared on his skin. It was described as mild, non-painful, and self-limiting. It resolved without treatment, and was never formally diagnosed. At the time, it was assumed to be harmless. But now, in the context of unexplained neurological decline, it becomes the first potential clue. Because in medicine, timing often matters more than the symptom itself. And what once looked like an isolated skin event may have been the beginning of something far more serious. In the days that follow, the patient's condition begins to change more rapidly. What was once subtle confusion becomes obvious cognitive impairment. he begins forgetting recent conversations entirely, not just details, entire interactions. Family members notice that he repeats questions within minutes, unaware that he has already asked them. At times, he becomes disoriented in familiar places. Rooms he has known for years no longer feel recognizable. Then new symptoms appear. Speech begins to slow. Not slurred at first, but noticeably delayed, as if each word requires effort to retrieve. Neurological examination confirms early motor abnormalities. His coordination is no longer precise. Simple tasks that once required no thought now result in small but consistent errors. Doctors begin documenting a pattern that does not match typical dementia. Because dementia does not usually progress this quickly, and it does not usually affect motor coordination this early. A second brain scan is reviewed. Still no tumor, still no stroke, still no structural explanation. Blood work is repeated. Again, no metabolic cause is identified, but the clinical picture continues to worsen. Over the next several days, additional neurological signs begin to emerge. His gait becomes unstable. He requires assistance while walking. Balance is no longer reliable. At times, he sways slightly even while standing still. Vision disturbances are also reported. He describes brief moments where his visual field seems incomplete, as if parts of his environment are missing for fractions of a second. Hearing also begins to feel altered. He reports a constant low-level noise that is not present externally. Doctors now recognize that multiple systems are being affected simultaneously: cognition, motor control, balance, sensory processing. This is no longer behaving like a single localized brain disorder. It suggests a diffuse neurological process. Something is affecting the brain broadly, and it is progressing faster than expected. At this stage, the initial diagnosis of dementia is no longer considered sufficient, because the trajectory does not fit any common neurodegenerative pattern, and yet every standard test continues to return inconclusive results. The medical team is now forced into a more serious line of thinking. If this is not degeneration, and not a structural lesion, then the remaining possibility is something far more concerning, a process that can remain hidden for years, before suddenly becoming aggressive. Despite extensive testing, no immediate cause is identified for the patient's neurological decline. At this stage, the medical team broadens their investigation further into his history. They begin reviewing older medical records, environmental exposure history, past infections, any prior neurological complaints, anything that could provide context, and then they find it. 12 years earlier, the patient had presented to a clinic with a skin rash. The documentation describes it as mild, localized, non-painful, and medically non-specific at the time. No laboratory confirmation was made. No definitive diagnosis was recorded. The patient was advised that it was likely a benign dermatological reaction, and no treatment was initiated. According to the record, the rash resolved on its own within a few weeks. After that point, there were no further complaints, no follow-up visits, no ongoing symptoms. For 12 years, the patient remained completely asymptomatic, functioning normally in daily life. There were no neurological issues, no cognitive decline, no physical limitations, nothing to suggest an ongoing disease process, which is why the current situation appears so disconnected at first. At this point, clinicians also review aspects of his personal history that may not have seemed relevant at the time. 12 years earlier, the patient reported a period of multiple unprotected, intimate encounters. There were no immediate symptoms afterward. No testing was performed, and no diagnosis was made. At the time, it did not raise concern, but in hindsight, it represents a potential point of exposure that aligns with the timing of the first skin reaction. A sudden neurological collapse, occurring after more than a decade of normal health, does not fit most standard medical patterns. However, when the timeline is reconstructed more carefully, a different possibility begins to emerge. Because in certain infectious diseases, the absence of symptoms does not always indicate resolution. Some conditions enter a latent phase, a period in which the disease is still present in the body, but clinically silent. No rash, no pain, no obvious signs of progression, just biological persistence without outward expression. And if that is the case here, then the current neurological decline may not represent a new illness at all, but rather the delayed progression of an old one that began with a seemingly harmless skin manifestation more than a decade earlier. At this point, the medical team begins to shift away from broad differential diagnoses. The pattern is no longer consistent with primary neurodegenerative disease. The rapid progression, multi-system involvement, and absence of structural brain lesions suggest a different category entirely. Attention turns towards systemic conditions that can affect the nervous system over long periods. Autoimmune disorders are considered. Specific neuroinflammatory conditions are reviewed, and infectious causes become a primary focus. A full infectious disease panel is ordered, including tests for slow-progressing pathogens known to remain dormant in the body for years. Initial results, however, do not immediately provide a clear answer. No acute infection is detected in standard screening, but clinicians note something important. Certain infections do not always present clearly in early blood testing once they have entered a latent stage. Further testing is therefore initiated, including cerebrospinal fluid analysis. The procedure confirms abnormal inflammatory markers within the central nervous system. There are signs that the immune system is actively responding to a persistent process, but the exact source remains unclear. At this stage, the medical team begins to compare the patient's clinical presentation with known patterns of latent infections that can later reactivate and affect the brain. One condition in particular begins to match several key features: a history of an initial skin manifestation, a long asymptomatic latency period, and delayed neurological deterioration affecting cognition, motor control, and behavior. However, despite this alignment, a formal diagnosis is not yet made, because confirmation requires correlation across multiple tests, and not all results are definitive at this stage. Specialists begin to debate whether the condition could represent a late-stage systemic infection that was never fully cleared from the body. But without definitive laboratory confirmation, the diagnosis remains provisional. Meanwhile, the patient's neurological condition continues to deteriorate. Memory impairment becomes more pronounced, speech becomes increasingly difficult to maintain, and motor instability progresses to the point where independent movement is no longer reliable. The team now recognizes a narrowing field of possibilities. There are very few conditions that can remain completely silent for over a decade and then re-emerge with this level of neurological aggression. And with each ruled-out diagnosis, the list of remaining explanations becomes shorter, until only a small number of possibilities remain, one of which aligns almost perfectly with the patient's entire timeline. But before it can be confirmed, one final step is required: a definitive diagnostic test that will determine whether this is truly a latent systemic infection finally reaching the nervous system, or something even more unusual still. If you're fascinated by real medical mysteries like this, share this video and subscribe to this channel. And if you value these videos, there's a free link in the description and pinned comment that helps support the channel. Every bit of click helps us continue researching and telling these stories, and it's completely free. Because most people have never heard of this, and wait till you hear this, might be even more dangerous. After extensive review of all available test results, imaging, and cerebrospinal fluid analysis, the medical team narrows the diagnosis further. The pattern of disease progression, combined with the timeline and neurological findings, becomes increasingly consistent with a single infectious cause, a chronic systemic infection with a known latent phase, one that can initially present with a mild skin manifestation, then remain clinically silent for years, before reactivating and affecting the central nervous system. At this point, confirmatory testing is prioritized. serologic testing for specific bacterial infection markers is performed. Both non-treponemal and treponemal antibody assays are ordered to determine past or present exposure. The results return positive, strongly positive, indicating previous infection that was never fully eradicated. Further cerebrospinal fluid testing confirms active involvement of the central nervous system. The findings are now consistent with a late-stage systemic infection that has progressed into neurological territory. At this stage, the diagnosis is formally established: neurosyphilis, a late manifestation of a long-standing infection that often begins with a transient skin lesion known as a rash, which can resolve spontaneously even without treatment. This explains why the initial symptom disappeared. It did not resolve because the infection was gone. It disappeared because the disease had entered a latent phase, remaining in the body without obvious external signs. Meanwhile, slow biological progression continued internally. Over years, the infection eventually reached the nervous system, leading to progressive inflammation and damage within the brain. This process accounts for the patient's current symptoms: cognitive decline, memory impairment, speech disturbance, motor dysfunction, and the progressive loss of neurological stability. What initially appeared to be a recent and unexplained neurological condition is now understood as the delayed consequence of an infection acquired over a decade earlier. The rash was not the resolution, it was the beginning, and the absence of symptoms for 12 years did not indicate recovery. It indicated silence, a period during which the disease remained hidden while continuing its progression beneath the surface. Following the confirmed diagnosis, treatment is initiated immediately. Antibiotic therapy targeting the underlying infection is started without delay. The objective is to eliminate any remaining active bacterial presence and prevent further progression. However, at this stage of the disease, clinicians are aware that treatment does not guarantee full neurological recovery, because the central nervous system has already been affected, and damage within brain tissue is often not fully reversible. The patient is also placed under close neurological monitoring. Additional supportive therapies are introduced to manage cognitive impairment and motor dysfunction. In the early phase of treatment, there are signs of partial stabilization. Progression of symptoms slows, and in some areas no further deterioration is observed. However, existing deficits remain. Memory impairment persists, speech difficulties do not fully resolve, and coordination problems continue to affect daily function. The infection appears to be controlled, but the neurological consequences of the delayed diagnosis remain. Specialists note that the outcome is heavily dependent on the duration of untreated latent infection. In cases where the central nervous system has been involved for extended periods, full recovery is uncommon. The patient is discharged into long-term care planning with ongoing neurological follow-up. At this stage, the focus shifts from cure to management. The priority becomes preventing further decline rather than restoring full baseline function. In the final review, clinicians emphasize a critical observation. The initial rash, which had resolved on its own more than a decade earlier, was the earliest visible sign of a systemic infection that remained undetected for years. Its disappearance did not indicate recovery. It indicated a transition into a silent phase of disease progression. By the time neurological symptoms appeared, the infection had already completed years of hidden activity within the body. What followed was not a sudden illness, but the delayed outcome of a long process that began with a symptom that seemed insignificant at the time, a rash that went away, but the disease that caused it did not. If you made it all the way to the end, thank you. These stories take a lot of research to put together. If you'd like to support the channel, you'll find a free link in the description and pinned comment. Checking it out helps support future videos, and every click allows us to keep bringing these cases to the channel. Also, it's completely free. And if you learned something from this case, like Share and subscribe for more real medical stories. And if you chose not to subscribe, leave a comment and tell me what would make these videos better. I read far more comments than you might think. I will see you in the next video. Good night.
This is Hidden Pathogens?